Good afternoon, everyone. This is Zach. I think just another minute or so and we'll get going.
Hey, Zach, can you hear me?
Sure can. Hey, Commissioner.
How's it look so far? You think we can get started?
Yeah, I think
Or
we
you
can.
want me to give it a couple more minutes?
I think we're in a good spot to get going.
Okay. I'm actually just had computer trouble, so I'm joining from my phone as we work on getting the computer working. So perfect timing. And now we're back. Okay. So welcome everybody. Zach, you could still hear me, right?
Yep.
I'm probably going to drop off camera shortly, but welcome everybody to our board meeting this afternoon. Just as a reminder to everyone, if you could please mute your line if you're not speaking. We also ask that you identify yourself in the organization before you speak. If you are on the phone like I was and logged in via web, if you could turn off your computer speakers, that helps eliminate some feedback. So with that, we'll call the meeting to order and I'll get started with the roll call. I am here. Cheryl Kashuba is not able to join us. I have her proxy though this afternoon. Megan Barber on behalf of the Department of Health, are you here?
Yes, good afternoon, I'm here.
Hey, Megan. Jessica Brooks.
Hello, I'm here as well.
Good afternoon. Frank Fernandez.
I'm here. Good afternoon.
Good afternoon. Antoinette Kraus. Antoinette, are you here? I don't see her. I'm trying to look if I see her name. Okay, we will pass for now. Laval Miller Wilson.
Good afternoon, everyone. I'm here.
Hey, Laval. Alexis Miller.
Hello, I'm here.
Paula Sunshine. Paula, are you there? Okay. Is there a representative of the Department of Human Services?
Yes, this is Kathy Burig, Department of Human Services.
Thanks, Kathy. And Tia Whitaker.
Present and accounted for. Good afternoon, folks.
Very good. Thank you. One more call for Antoinette. How about Paula? Okay, Zach, as of right now, they are absent today. So the minutes, you all should have a copy of the minutes before you. It was distributed with the meeting materials. Can we have a motion to adopt the minutes?
So moved. This is Laval Miller Wilson.
Second, Frank Fernandez with capital.
Very good. Thank you. Any comments about the minutes? All those in favor?
Aye.
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 Any opposed? Hearing none, motion carries unanimous. I see now Paula has joined us, Zach, so we'll make that note. Before we get into the meeting, the additional meeting agenda items, we provide an opportunity for public comment. So please note that public participation is permitted at this meeting as required by the Sunshine Act. In the absence of official policy relating to public comment at board meetings, And to ensure the orderly progress of today's meetings, all comments should be directed to the chair and should be limited to no more than 5 minutes in duration. Questions asked of the chair or the board as part of public comment may or may not be addressed at the meeting. So with that, I will open it up for public comment. All right. Hearing none, we will move right into the meat of the agenda, starting with administrative matters, and I will turn it over to Heather to talk about the Q1 financial statement.
So if I can, this is Zach, I can jump in to kind of give a brief overview here. We did provide the quarterly financial statements in the pre-read materials. As a very quick summary, it reflected that we were on budget or a little bit under budget, and that revenue is coming in as expected. We do have a pretty lengthy and busy meeting today, so we thought in the interest of time, we'd take any and all questions you might have on those materials, and we do have the financials in the appendix, and we can pull them up if you'd like. But we thought, in the interest of trying to save time, we would not go through them slide by slide.
Very good. Anybody have an objection to that or any questions? Then we will consider them submitted and move on to the next item, which is a report from Zach on hiring the chief of DEI. Zach?
Yeah, we thought it would be beneficial to give you a brief update on where we are in the recruitment process for the Chief of Diversity, Health, Equity, and Inclusion position. We are in the interview stage of the hiring process. We have a number of what I believe to be very qualified and exciting candidates. The first round of interviews, which is ongoing right now, has 6 very qualified candidates. We're in the process of getting through the first round this week, which will be followed by a second and final round, and then a selection. So we're hopeful to be through that process in a couple weeks, and to be in a place where we can bring someone on board in the coming month or so and get going with that position. So that's the update. Any questions?
Zach, this is Tia. Is it possible you can provide the board with an updated org chart?
Yeah, absolutely.
Okay, great. Thank you.
We can do that in follow-up to this meeting too.
Sure. Very good. Thanks, Zach. Thanks, Tia. Any other questions for Zach? With that, Zach, we are way ahead of schedule and about to slow down considerably. So I will turn back to you to talk about the PHE.
Thanks, Mike, or thanks, Commissioner. So I think the big portion of today's session is to give you a report out and to consider some policies around the unwinding of the public health emergency, which is potentially upon us. We've had discussions on this in several meetings over the last year, and we've done a whole lot of work in partnership with the Department of Human Services, as well as the federal government and other stakeholders around planning for the unwind of the PHE. And so we have a number of items we want to share with you today, as well as 2 potential policies for around special enrollment periods that are designed in the interest of trying to make the transition from MA over to coverage through Pennie as seamless as possible. So let me start at the top with a kind of an overview of some emerging timelines, what we know about what's going on with the end of the PHE. as well as, how it's going to be operationalized here in the Commonwealth. So starting at the top, since our last meeting, the PHE was extended another 3 months with a current end date of July 15th. What that means is that the earliest possible terminations coming over from DHS or for people no longer qualified for medical assistance associated with the PHE would be August 1st at the earliest. What this means is that the majority, if that's when the PHE ends, what that means is that the majority of the PHE unwinding work will now coincide with our 2023 open enrollment period. And as it currently stands, with the expiration of the American Rescue Plan subsidies, which under current federal law are now are only available to Pennie customers through the end of 2022. So those are a couple of big things. Obviously, open enrollment 2023 is going to happen. The future of the American Rescue Plan subsidies, and I think the extension of them are very broadly and widely supported. That is still an open question. There's been a whole lot of, I think, advocacy kind of across the board for the extension, but it is the congressional path for that happening is a little murky at this point. So any questions about the potential end date of the PHE or anything else I just said?
I appreciate going step by step through these. It's Laval. I wonder if Zach or you or others, because I know our board members have expertise in some of these areas too. So the PHE has been continued, I think to date 9 times. There may be a 10th. I understand the main implication is, well, my question is, are you hearing anything, or when might we be hearing about when the 10th could come? Would it be this month? And what would that look like in terms of timeframes? I'm anticipating even a 10th extension would still put us into the coincision with OEP 2023, but just because it always seems every month brings still a possibility of another one going forward. Can you just share what date we're looking at this month?
Yep, definitely. So the time frame that we're looking to right now is 60 days prior to July 15th. And so that's sometime in the next, I think 5 to 7 days. And what the implications of that date is around if it's going to end, which means the feds have committed to telling the world 60 days in advance of the final end of the PHE that they are not going to extend it. So there's broad federal government commitment to telling states 60 days in advance if they're not going to extend. What that doesn't necessarily mean is that they're going to tell us in 5 to 7 days that they're going to extend it for a full 90 days or any other time period. And you may recall this happened the last time around. Everyone was waiting with bated breath 60 days prior to April 15th for an announcement, and no announcement came. And kind of much later, we were told definitively that means that it's going to be extended. I can see the feds waiting. If they're going to extend it, I can see them being pretty silent in 5 to 7 days again, and waiting much closer to July 15th to actually formally telling the world that they're going to extend again. And if they do, to your point, if they do extend, they can only extend 90 days at a time, which would put us at a place of October 15th.
Got it. Thank you.
Any other thoughts or questions on that timeline?
The delay would still get right into the coincision with OEP 2023.
Yep, that's right. I mean, there's a lot of speculation that if they delay once, they're going to delay twice. But I don't, the challenge for us is that they can only formally extend it 3 months at a time. And I don't think that they've not yet demonstrated a practice of signaling their long-term plans around the PHE. So if they do extend it, but if they do extend it and don't provide any additional clarity, then we'll just have to kind of pivot our prep and launch activities to October 15th and kind of go through this whole process again.
Right. So I think that's it. I just wanted to start off with that date and recognize that these next couple weeks, folks that have been paying attention to this are mindful that there's a date over the next 2 weeks where we may learn whether the July 15th has been moved into October 15th. But it may also not come up in the next 2 weeks either. It could be a little later on in the into June. Correct?
That's correct. And I don't think much of our, our operational planning can be adjusted, even if if we do learn that it is extended another 3 months, just because, much of what we're working on is trying to make this go as seamlessly as possible around the complexity of open enrollment, and that factor won't change with a 3-month extension.
Right.
So the other, moving down to the next item, we have not discussed this in this forum, but it's been known for quite a while. The process that the Department of Human Services has landed on for processing renewals, for getting through the backlog of folks that have been kept on MA and overdue renewals is a 6-month timeframe. So that is going to be a pretty large volume in a fairly short period of time. And that, it's important to call out that we've not actually operated Pennie outside of the public health emergency, outside of the pandemic. And so we've never really had normal operations, normal redeterminations. And so we will be going from really having very, very low volumes coming over from DHS to historically high volumes, which will be moved through in a fairly condensed time frame.
Hey, Zach, we had a question from Paula.
Paula?
One
Paula?
mute, sorry. Is it anticipated that DHS will process these redeterminations in waves so that, a sixth of them will occur every month, for example? How is DHS thinking about the way that they're going to start to initiate this?
Yeah, and that's a great question. And I will say, I don't want to speak on their behalf. So I think, Kathy, if you could add in here, if you're willing, I would say it is anticipated to be in waves. It's anticipated to be staggered. It's not going to be all of the ones that would come our way in 1 month. It will be split across several months. Kathy, would you add anything to that?
Sure, Zach, thanks. That's correct. I mean, we would be looking at dividing the number of cases that need to be reviewed over the 6-month period of time. And just to add a little color to that, that would be in addition to the regular renewals that are processed for each of those months.
Thank you.
Thank you. Okay, Zach, I think you're in row 3, maybe.
Yep, the other piece about the processing timeline is that CMS provided states clarity around when they can get going. And so state Medicaid agencies can begin the reprocessing of renewals up to 2 months prior to the end of the PHE, which would allow them to start the process in a way that allows the first wave of terminations to begin right after the month after the PHE ends. So if the PHE were to end on July 15, that means DHS could start the reprocessing process in June, with some people losing coverages beginning in August. And for us, that would mean that sometime in late June, early July, we would start getting the account transfers over from DHS for the potential for people to start signing up for coverage effective August 1. All of the timelines, it's worth noting that we'll go through today are subject to change and are illustrative in nature and aren't necessarily exactly how it's going to play out. We wanted to give you a sense of how it could play out, but a lot of this stuff is still in flux. So please take that with a grain of salt. So the last item that we wanted to share as an update from the last time we talked is around, something that we had a really good discussion on a couple meetings ago, and this is for the folks that do not respond to DHS's renewal request, the renewal packet, after a certain period of time. When they don't respond, they are deemed, not responsive and no longer eligible and are what's called procedurally terminated. This is the population that we had a discussion about, really wanting to have as many opportunities to reach them as possible. And when we discussed it last, it was something that we felt we did not have authority from the federal government for DHS to share information with us, with the marketplace, for purposes of conducting outreach. And the good news is we've been able to work that through with CMS, with DHS, and gotten to a place where it is permissible for DHS to share that information with us for purposes of conducting outreach, in the interest of trying to get them covered. So the process there still has to account for some procedures over at DHS that allow people the opportunity to come in a little late or allow people the opportunity to appeal. So we will get that information on a monthly basis, but it's going to be on a 1-month lag. So if someone loses coverage through the procedural termination process, let's say they lose it on July 31st, we won't get that information for purposes of doing outreach until August 31st or August 30th.
Any questions for Zach on anything on this slide related to timelines? Okay, Zach, then I keep it going.
All right. The other thing we wanted to kind of share with you is a sense of what we're talking about in terms of volumes, in terms of folks coming our way through this process. And so, at the top, and these numbers are continuing to change as we move, but at the top, DHS has estimated that enrollment through the medical assistance program has grown to over 3.4 million people throughout the PHE, some 950 of which could be ineligible if not for the continuous coverage requirement. That's not to say that they're definitely ineligible. It's to say that some have been redetermined through this process and held, even though they appear to no longer be eligible, and some have overdue renewal applications. The breakdown there is that there are about 500 individuals who would have been declined but have been kept and flagged in the have been kept and enrolled but flagged as such. There are roughly 600,000 who have overdue renewals. Those numbers don't add up to 950 because, but there's overlap between those two populations. So combined, the two populations kind of represent the number of folks that need to go through this process, the renewal process, over a 6-month period. It's also worth noting, and Kathy just said this, that when the PHE ends, DHS will resume normal renewal processing. So there's a third bucket of folks that will be potentially coming our way through that process because they have to, every month some subset of the MA population is up for renewal and needs to be redetermined and reprocessed. We have very little to draw on in terms of historical context. The one data point that we have is that prior to the pandemic, account transfers from DHS came over as at a rate of roughly 11% of the population that was eligible for renewal, which amounted to roughly about 27,000 folks a month. We think that in some cases that percentage is appropriate. We think in others, particularly for the folks that are in the category of held on MA, but determined ineligible otherwise, the 500,000, we think that there will be a higher percentage of those that come our way. And so making, a fair amount of assumptions about what will happen and, not having a ton of historical context or experience to draw on, we think that during the 6-month period, that we will potentially expect to receive between 45,000 and 61,000 transfers of application transfers per month throughout the 6-month period. Any questions about that?
Zach, we don't have a good idea of how many may have employer-based coverage, do we? If we look over at the last couple of years since pre-COVID, I think we've seen almost 200,000 off the commercial rolls from small and large group policies. And I don't know, I mean, some of them, unfortunately, were probably lost their jobs or maybe businesses closed. But have you seen anything to suggest percentages of individuals in this population that may have access to employer-based coverage?
I haven't seen much. There was one Urban Institute study that tried to, make some national estimates, and I think I'm not remembering what the employer-based numbers were. I have a sense of what they thought. I do remember what they thought would come over to the marketplace. But I will say they thought the majority of folks would be eligible for job-based coverage, or the largest plurality. And they thought that roughly 30% of the adults would be eligible for marketplace coverage and about 9% of kids, which I think boiled down to about 24% of people going through this process they thought would come over to the marketplace. But I think to your point, a lot of them are going to be, I think there are 4 places they can go. One is they stay eligible and enrolled in Medicaid and medical assistance. 2 is they have access to job-based coverage. 3 is they have access to marketplace coverage through Pennie and financial assistance. And 4 is they go uninsured. Obviously, we're very eager to get them into one of the first 3 buckets and to do everything that we can to prevent them from falling into the 4th bucket.
Yeah, I think, as I recall, at Jessica's last board meeting, we adopted some thoughts along the lines of trying to do what we can to help those individuals out. Any other questions for Zach on the unwinding or the quantification of the unwinding? Okay, well then, Zach, I think is it still you, or are we moving over to Jennifer to talk timing? I think Jennifer.
We're gonna kick it to Jennifer to talk us through
Great.
this.
Great.
Good afternoon, everyone. So as we mentioned here, for the first time, we are sharing a unwinding timing scenario with some level of specificity. To date, we've only ever shared phases of work to be completed, but as Zach mentioned, there has been some emerging guidance from CMS and conversations with DHS partners. So we're able to share this today with some caveats. The first is that this is assuming a PHE end date of July 15th. If that is extended, this timeline will need to shift. The second is that because we don't know specifically if 7/15 is the end date, we also don't know the exact dates when DHS reprocessing will begin or end. So for the purposes of this timeline, we have included the assumption of a start date of June 1 for reprocessing, and then that all needing to be closed on the 6-month timeframe, which takes us to January of 2023. So this timeline visually depicts all that needs to happen to properly unwind the PHE. And it was our intention to share this first before we dive into some deeper conversations on our marketing and communication strategic decisions and some additional policy proposals that we'll be sharing later in this presentation. We wanted to use this time frame to frame those conversations. So you'll see on this slide the impacts of first DHS only having from June to January of 2023 to reprocess all of these individuals. And second, the impact of a 7/15 PHE end date and how that coincides with open enrollment. So there are some apparent risks that I think are displayed here. The first being that we will be receiving significantly higher account transfer volumes that directly coincides with OEP, which is already our busiest time of the year. And there's also the potential for customer confusion as they're trying to sign up for 2 plan years at one time at the end of 2022, and then also enrolling for open enrollment in 2023. So these are risks that we are aware of, we're tracking, and again, you'll see in the following slides some of our attempts to mitigate those risks through some policy proposals, different technical functionality, and some of the strategic decisions on marketing communications that will be discussed more in depth. The final item I'll just touch on with this slide is the addition of the receipt of the procedurally terminated customer information. So as Zach mentioned at the top, that was a new development that we are very excited about, the ability to do direct outreach to these consumers and try to get them enrolled. You'll see here that receipt of that information would start in the end of August of 2022. We would be receiving those files monthly, so that would run through the end of February of 2023. So as you can see, again, it directly overlays with open enrollment preparations and operation as well. So although, as I mentioned at the top with the caveats, it's not a concrete timeline yet until we do hear from CMS on the actual end. This is a pretty realistic timing scenario and provides a clearer picture on what we're expecting in terms of preparing for the PHE unwinding, and also giving us a little insight into how we can strategically prepare to react with the information that's coming our way.
Very good. Anybody have any questions for Jennifer?
A terrific chart. There's a lot that's here. I'm wondering if you could just unpack this, going backward from what you said, Jennifer, just to unpack the slide a bit. That August date to the end of August. I'm reading out loud. I don't mean to insult the intelligence of any of my members. I'm trying to process this a bit myself. So August 1st of 2022 is the first date consumers in Pennsylvania that are in Medicaid could begin losing their Medicaid based upon an ineligible determination. It doesn't mean everybody. Paula asked that question about you're going to do this in waves and got the confirmation that that would happen. But that's the first day on this slide that says a significant number of consumers could begin losing their coverage. And then the first opportunity for Pennie to reach out to those members comes at the end of August or in September, right? That's when, or at least Pennie probably isn't going to reach out to those folks at the end of August. It's saying you get the file at the end of August. You or we get the file as Pennie about that. And now at the end of August, really beginning of September, going forward, we can start to reach out to those folks to say you're interested. I'm going to do a stop on that. Yeah.
Not quite. So
Okay.
for a subset of the population, yes. But for the people that do respond to the renewal packet, who go through the redetermination process, are deemed ineligible for MA and potentially likely eligible for coverage through Pennie, they go through the account transfer process beginning as late as June, as early as June and through July. Those will come to us through the account transfer process. That initiates a number of things that allows us to send them a notice, create an account, to the extent that the auto eligibility functionality that we're looking to put into place works. It spits out an automatic eligibility determination that would go to them in a notice. So we will be doing outreach and customer engagement to people that come through the account transfer process in advance of when they lose coverage. It's the people that don't respond, who are procedurally terminated, who we won't get their information until a month after they lose coverage, and that's when we can start reaching out to them. Did that clear it up for you?
Yes, and I'm circling back to I mean, I appreciate seeing the slides in advance. The number of people that would be in this category of being procedurally terminated, it's not necessarily all that clear to us yet as to how many.
No, and we don't know that number. And the numbers, the 45 to 61,000, are estimates of account transfers, not estimates of the procedural termination group.
Oh, okay. Can you go back to that slide for a second?
Yep.
So that last bullet is Pennie estimates that it can expect to receive between 45 to 61,000 account transfers per month during the 6-month period. Over a total of 6 months, that's at a bottom line, that's a low of 270,000 account transfers using the 45 figure to, a much higher number. But that doesn't include and so there'll be outreaches potentially out to that group, but we don't know how large and what that group looks like of this issue of the procedural. I'm blanking on the term again. Procedural
Terminations.
Terminations, right?
Yeah, that's right. You got it. The 45 to 61,000 is the path that we want them to come through. It's the much easier, more straightforward path. If they get to us from DHS, they'll have recently responded to DHS. So we'll get kind of current eligibility information. We should be able to run a determination off of that. We should be able to directly send them information about what they're eligible for, how much financial assistance they could receive, and we'll create an account for them, and they'll have an ability to come through and get covered, and they'll have an SEP period that's automatically kicked off for them.
Okay.
So just to round it out, Zach, it's about 150,000, if it's divided equally by months, out of that 900,000, 150,000 will be in the top of the funnel every month. And the happy path looks like, it's roughly a third of those are going to go through the redetermination and become account transfers. And then to your earlier point, out of the remaining 100,000, some, although we don't know how many, might end up in group coverage. Some will pass the redetermination criteria and stay in Medicaid. And then some will ultimately, fall through the cracks and be uninsured. Is that kind of the whole thing?
Yep, that's a really good assessment, Paul. And my only tweak is that 950 is a subset of everyone going through the renewal process, because as Kathy mentioned, in addition to the 950, there's just the normal monthly renewal process. That is another bucket of folks that we have incorporated into our estimate of the 45 to 61,000.
And then to follow, this is Alexis, to follow on Paula's example there, the folks who would, quote, fall through the cracks that are in that 100,000 are falling through the cracks because they have not provided any of the substantiating materials to DHS. Is that the only reason they fall through the cracks at that point? Because otherwise, if they had, an account transfer would happen, or we'd know they have group coverage.
I would say we have a much better chance of ensuring they don't fall through the cracks if they are responsive to DHS and they get to us through the account transfer process.
So this is Tia, just a question. For those who are procedurally terminated, 30 days after they're procedurally terminated is when outreach will begin. Will that outreach be done by Get Insured, or is there some other path to do that outreach to these folks? And will that reduce their time for special enrollment period from 60 days technically down to 30 to reply for coverage?
So we can get into the different ways in which we plan to conduct outreach, but primarily it would be from Pennie, and we can do a number of different modes of outreach, including emailing them, mailing them, calling them through Get Insured if we have their calls, if we have their phone number and the ability to call them. But we don't have any current plan or ability to share that information outside of Pennie. And your question, Tia, about the SEP is tied to their loss of coverage. So it would be 60 days, or we're talking today about making that 120 days, but it's 60 days from when they lost coverage. So it would be, we will start, if it's 60 days, we will get the information 30 days into their 60-day SEP, and we'll only start conducting outreach to them in the remaining 30 days of their SEP. Prior to getting, for what it's worth, prior to getting the kind of the permission, the authority to for DHS to share that information with us, we were looking at DHS sending them a communication, but having to wait until 90 days after they lost coverage. So we are, while this is not perfect, this is way better than what we were looking at previously.
And Zach, this is Kathy. If I can just add on for folks, so there's just level understanding. The reason we're giving the 30 days is for the individual to get the opportunity to receive notification from DHS that they have been terminated, and to give them the opportunity to either file an appeal, which could help them maintain coverage, or to provide the information that was missing so that we could reopen them. So it's not that they're necessarily sitting with no communication for that 30 days. They do have notification, and they do have some follow-up action that they can take in order to maintain that Medicaid coverage.
So a lot of really good questions, and thank you, Kathy, for filling in that context. Maybe we could go back to the timeline slide, Kelsey, and any other questions about this timeline?
Zach, I think that moves us over to your communications and marketing effort, and Chachi.
Sure. Yep, I can jump in. Good afternoon, Commissioner, directors. I really wanted to jump over to this slide while we were having this discussion, because I think that these two populations here help us, look at the account transfers and those being procedurally terminated. But again, with the caveat that we're working with the July 15th ending of the public health emergency. So whenever it comes to our communications marketing efforts, it really all comes down to, our populations, your target audience, your timeline, and tactics and budget. So starting with our populations, which have already been discussed, is that first population going through the happy path, responding to the packets, determined ineligible, and get transferred over to Pennie. The second, either not responding to the renewal packet or not sufficiently completing it, and they're procedurally terminated. We now have the ability to contact them, prior to the conclusion of that, reconsideration period. Our messaging here is really to encourage that coverage can continue, provide different education of the pathways to that, either responding directly to the renewal packet, getting them into that flow, or applying directly with Pennie. So again, this timeline is kind of could be overlaid with the timeline on the previous slide, where the outreach to the transferred population will be kind of ongoing and will start late June, early July. And when the PHE officially ends, that's when our current plan for our media buy will start in August, with that broad message of, did you recently lose coverage? And Pennie being an avenue to keep that coverage. Then, as we were discussing earlier, the outreach can begin to those procedurally terminated customers, and we'll get into those tactics in later slides. But as Zach said, the ability for postal mail coming from Pennie, which will also be co-branded with DHS's logo, so we show that handshake, and emails and phone calls. Overlapping with our open enrollment efforts, the 2 stars, the beginning and ending of open enrollment. So our open enrollment ad campaign wraps up in January, starting into our SEP communications, and then taking us all the way out to May, with the caveat of the possible extension of that SEP. And all throughout this, there's consistent and constant communication with stakeholders and media and various partners, so that everybody's kind of on the same page with all of these efforts. I'll pause there for any questions in the Marcom timeline.
Yeah, Chachi, I have a question and would be interested in board members' thoughts too. Is August 1 a little bit later than, like, as we kind of talk about actually losing your coverage, should we start a week or so ahead of August 1 as maybe some notification is going out, or why did we land on right when the coverage is expired or terminated?
I think from my perspective, it was to reduce confusion. We're kind of always consistently running search and social ads during SEP to at least create awareness for those that are looking for coverage outside of open enrollment. So we're, you know, in a digital sense, consistently in the market for that. But I think that the idea there was to not create too much alarm for the vast amount of the population for the renewal, since this is the very, very start of it in August.
Okay, thanks. Anybody else have any thoughts on the August 1 date or anything else from Chachi?
It's Alexis. Can you tell me again, in this scenario, what the earliest date that a Medicaid member would know that they are losing coverage would be relative to that August 1st date?
Sorry, Alexis, the question is the earliest they could know?
What is the earliest that they would hear? So if I know we don't know this, but if we're processing a sixth, of the redeterminations at a time, and we say, you know what, somebody has provided their information and they are definitely, going to roll off the medical assistance books.
I think for the folks, and Kathy, please correct me if I'm wrong, but I think for the folks that respond, it's when they respond and then the redetermination happens, they get a communication saying you're losing coverage effective this date. And, you know, that could happen as early as late June in this scenario.
Yeah, so
let's,
from
sorry.
sorry. So we're required to give at least 15-day notice to individuals prior to losing service. So we would tell them 15 days in advance, as of this date, you will lose eligibility. In general, regardless of what that date is, coverage continues through the end of the month based on capitation payments.
But so asked another way, so somebody gets the notification from Medicaid that they need to go through the redetermination process. They submit all their paperwork and to DHS. About how long will it take? Are you estimating that it's going to take DHS to get to a determination?
So obviously it will be different for everybody because we can't process everyone's in the same day, but they're all due to be completed by the end of the month in which they are due. So if they are due in the month of July, everything that's due in the month of July is to be processed and completed by July 31st. Notifications would then be sent by mid-August and termination would be effective August 31st.
It's Alexis. I guess going back to the commissioner's question, it does cause me to wonder if there's room for some elements of earlier processing so we're not so, compressed for time on the back end where somebody is just being notified at the end of July that, they're losing coverage at the end of August. And then the race is on to try to make that, get in touch with them in that 4-week period and make things happen. I
Are
don't
you
know what
saying,
the answer
can I
without
just ask for a clarification? I mean, that's an excellent inquiry, Alexis. Are you saying, you said processing, you mean the outreach, kind of going to the Chachi's question or the commissioner's question about, can we begin the outreach earlier? Not necessarily the processing earlier, or is it the processing?
Well, maybe I am asking the question on processing. Like, I guess I heard that we are required to notify them with 15 days advance notice. What is the other end of the boundary? Like, what's the other constraint? We can do it as soon as 2 months?
60
Is that
days. It's 60 days before, right? That's the new window that's opened, right? So if we take one person and put them on an optimal path, what does it look like in terms of timing? The most optimal path. So late June, no, 60 days prior. So June 1st, DHS has the ability to start processing. I don't know. I think we need a little help here.
So we technically cannot terminate until the end of the PHE, so no terminations could happen prior to whatever the last day of the PHE is. Our systems are all set up to provide 15 days notice. As many of you on the phone are aware, we process more than just Medicaid. Oftentimes people receive more than one benefit, so it's 15 days across the board, and it works on a monthly cycle. So as I explained a little bit ago, somebody whose renewal is due in the month of July, they get the information to us in July. We process by the end of July, and their notification goes out with termination of coverage beginning in August. The end of August, sorry.
And Kathy,
Well, what happened to that? Oh, that's that 60-day. That's why that's the first half of the 60-day period is eaten up by just the mere, administrative processing. That was the point earlier.
Was there someone else trying to jump in?
I think Alexis was.
Yeah, I was going to say, well, I guess that answers the question then on the processing time constraints. Then back to Laval, you're in line of questioning on outreach. Is there anything that precludes much more specific outreach about the likelihood that someone might be redetermined, and if and when they receive this notice, they need to take these steps? Like, how explicit then could earlier outreach be in advance of a processed redetermination?
So I'll offer that. I worry about explicit outreach and communications prior to the processing, because the processing could result in them just staying on MA.
I mean, do we have any information that make us more likely to know the likelihood of groups of the members staying on MA versus the likelihood of them being reprocessed, or we don't have any of that data today?
Well, we have some of
The
that.
state, yeah.
I guess we have some of that. Can we go back a slide to the numbers again? I just want to, one more, that one. I just want to unpack the 950 of the first bullet point, speaking to this question that Alexis was going. I'm jumping in. I think DHS might well answer. I'm going to give a shot of 500,000 are on Medicaid who should not be on Medicaid, but DHS, but for the PHE, is keeping them on. They moved. income may be over, but we're in a public health emergency that's constraining the state to say we can't get them off.
Well, I'll just offer that everyone has to go through the renewal process. So I think there is a potential for some of the 500,000 to respond to that and respond with information that results in them staying on MA. So I think right now DHS has them as, otherwise ineligible, but everyone has to go through the renewal process, and to the extent that they respond and they are eligible or they're qualified, they'll stay on MA. I don't know if that changes any of your points, but I just wanted to try and make that clear.
But I think what we're grappling with is how many are eligible. I guess, Alexis, I was using this as an opportunity to share, get at the opportunity to switch over to Pennie. How do we get this group that's no longer eligible for Pennie that may well, and so I looked at this slide a couple times and looking at the detail of the numbers of how this might play out in terms of the outreach. It's a breakdown of the 950,000 that could be eligible if not for the continuous coverage. And it was helpful for me to kind of understand some of this breakdown and how outreach would play out. Still over a 6-month time frame.
Very good. Do you
No,
feel like you have a better idea, Laval, or do you have a follow-up?
No, I just think that it was really building on actually your point, Commissioner, and Alexis's follow-up of, okay, could we do outreach earlier? And I think from this conversation, I'm not sure if either of you or the group as a whole is satisfied with probably not. Given this time frame, it's going to start on August 1st.
I guess not conceptual. I guess what I'm hearing to Zach's point is it could be more confusing than it's worth, because we could be having very specific outreach to somebody who ends up remaining eligible for Medicaid. That's the bottom line, is that we're saying it is better to wait so as not to confuse and kind of knowingly compress then that outreach into the potentially 4-week time frame to try to make the move if in fact they're being redetermined off of Medicaid.
Unless that communication was more broad and it just reinforced the importance of timely returning your redetermination paperwork and kind of had a broader message.
So Paul, I think that's a great point. I was going to chime in to say, I think the message before they are reprocessed is respond to DHS. That's the action that we want folks to take. And I think, if we go back to the 4 buckets of folks that I talked about earlier, maybe with the exception of people who know they're not qualified and know they have access to employer coverage that's affordable. I think for the 3 other buckets, stay on Medicaid, go over to Pennie, or uninsured, the action we want all of them to take is to respond to DHS so they can get a fresh redetermination and go down any of the 2 happy paths. 1 being stay on MA, 2 being go to Pennie. So, I think your point is a really good one, Paul. Like earlier outreach can happen. I think But I agree with the sentiment that it should be broad and it should be focused on, you know, an overarching message of respond to DHS, get back to DHS.
Right. And in all this and in all the permission, which I think is great that Pennie has gotten from DHS, you know, whatever the timing is, are the navigators perceived as a designee of Pennie so that the navigators can be engaged in this process too, or is it solely limited to Pennie itself?
I believe it is restricted to Pennie and that for purposes of sharing data that they're not, we can't share it with them. But John, are you on? Did you hear the question and can you weigh in?
Yeah, I did. I don't think we've looked at some of the customer disclosures, and that data share is going to be with us. And for us to get them into the system, Paula, as soon as we do, we'll outreach and see if we can't get those extra permissions so we can work with our navigators and even the broker community. But that initial data dump to Pennie will be limited to Pennie and Pennie staff. That doesn't mean we might not be able to do some outreach through our call center. I'm working on that. Dwayne and I are going back and forth about what language we're getting and how we're getting it. But we're looking to put, not to quote Churchill, but we're looking at how many ships of sail we can put.
And I think just to add to that, the outreach that we do can be to say, you know, here's Pennie, here's how you can apply. And if you need assistance, we can connect you to an assister, we can connect you to a broker. But the handing over of the data is probably not going to be able to be possible. Kathy, I see you have a question or your hand raised.
Yeah, not really a question. I just wanted to try to provide a little information on what's happening before we start processing to color in a little bit for folks for the outreach. So the department has an outreach that we send to individuals 90 days in advance of us actually sending any packet to them, telling them that we're getting ready to process their renewal, to please provide us with any updates, because we try to do electronic matching first to see if we can renew without them having to provide additional information to us. If they can't provide that, if they provide information and we can't match electronically, that's when we send a packet to them. So in this 90-day process, they're getting a letter, they're then getting a renewal packet. We have close to 300,000 or 400,000 people who have signed up for text messaging. We're sending people a text message telling them, look for your renewal. If they haven't provided it within 10 days of the due date, we're sending them a reminder. If they haven't sent it within 5 days, we're also sending them a reminder. There is an outreach campaign that is being developed by the department as far as communication and timing. So I appreciate the conversation about how we can also direct them to Pennie, but I also appreciate Zach's point that we're trying not to confuse. So I think we're trying to make sure that for those people that we want to respond to DHS, that DHS is communicating to individuals. And then if they haven't responded to DHS, we're then allowing Pennie to take over the process of having that communication. I think that's what we're looking at, so that, to Zach's point, we're not confusing people where they need to provide information to or who they need to respond to.
Very good. Thanks, Kathy. Zach, I'm going to ask you to move into, and I guess it's Dwayne, to talk about some of the technical operational updates, because I think some are still related to this conversation. And I know a couple of the issues that we're going to talk about and potentially vote on today are also related all to the unwinding. So if you want to move on to the next slide, we can do it.
Yeah, that sounds good. Thank you, Commissioner. It's actually, Chachi's got a couple more slides on the details of outreach and communications. I think we've talked through a lot of them, so Chachi can probably be fairly prompt, but he's got a couple more slides.
All right, go ahead, Chachi.
Cool. Yeah, I'll clip through this as quickly as possible so we can get over to that operational side. Stakeholder outreach, owned media, earned media, paid media, and other outreach efforts. So stakeholder outreach is ongoing with both MCOs and QHP providers. We had a webinar last month to have a little bit of high level conversation with them of what we know, asking them any questions that they have for both Pennie and DHS. And I'll get to that on the next slide. We have our Pennie community work groups, various outreach presentations to really try to keep everybody up to date with efforts, we and DHS are conducting, as well as keeping them up to date on current timelines, and always kind of keeping that feedback loop open so that we're addressing any stakeholder concerns or anything that's kind of bubbling up from MA recipients or Pennie customers. Our owned media, or I'll stay with stakeholder outreach, is that both us and DHS are developing a stakeholder tool kit, which will include our normal toolkit materials, talking points, social posts, explainer videos, a glossary, so that we're all kind of using the same terms for everything. So we're not using, Medicaid in one line and medical assistance in another. For our owned media, at least from Pennie and DHS's side, various mailers, our notices, our emails, our outbound calling campaigns, our Pennie landing webpage, which will really get launched in end of May, early June, just in case we start to see that trickle come over with various questions, and then also our social media campaign. Earned media is has already kind of started with some various interviews that we've done in conjunction with DHS. And I think that this is a really great opportunity for our board members to get involved as well, whether that be mobilizing your network, writing an op-ed that we would be able to distribute through our various media contacts, but certainly invite our board members to really activate your network or using your voice and expertise to get the word out about these efforts, which we'll be in contact with various ways that all of you can get involved. Paid media, as you saw in the timeline, really runs from August through January. It'll be a good healthy mix of traditional, digital, out-of-home lifestyle tactics. There's your traditionals, there's your digitals on the second bullet point, sponsorships, transit, social influencer marketing, and lifestyle ads. And the plan in its current form is within our current budget, and it also includes the PHE specific $1 million that was authorized from the board. And then our outreach efforts are consistently ongoing, but really we have specific plans around reaching hospitals and health centers. Our YMCA Health Equity Tour, considering expanding that to maximize our reach, especially in higher areas of the state that there may be recipients of MA or uninsured. And then our sister network, activating them with various engagement partnerships and events, and then getting our sponsorships of various conferences and festivals and events around the state. So we're really kind of meeting people where they are. Any questions in the kind of tactics side of getting the word out?
Chachi, one question. Have we thought about using schools in the past? I'm a father of 3 elementary school students, and they each have a take-home folder. And this time of year, I get a lot of flyers for like a summer camp type of thing. And I know, because I actually attended one of the Pop Warner football board meetings, and they advertised through there, and they talked about how parents see the material going to elementary school students is much more effective than middle school students and high school students who tend to maybe get it back to their parents with less frequency. But is that something that we've ever explored or thought about, and maybe even like targeted a couple areas in lower uptake regions or anything?
Yeah, we've actually, through our outreach team, have made connections with, the Department of Education so that we can kind of work on that at a higher level. But certainly willing to explore other avenues of getting it in a granular level. And I appreciate you bringing that up. And being a father of two myself, it's good to see some education materials slipped in their scribbling coloring sheets. But thank you for that.
Yeah, exactly.
That's a
Any other
point.
questions? Thoughts from
So-
the group? Is that you, Zach?
Yeah, I was just gonna highlight what I think is a challenge that we've been grappling with internally, and I think with our creative vendor around like the reality that this is going to overlap. This is going to begin before open enrollment and overlap open enrollment entirely. And the message is not exactly the same as a open enrollment type advertising campaign, but having conflicting campaigns at the same time is a challenge in itself. So I don't think there's a perfect answer, but I wanted to just kind of pose that challenge that we're grappling with to see if anyone has any thoughts or feedbacks or great ideas.
Anyone?
Well, isn't
Okay.
it, just a quick
Go ahead,
reaction
Laval.
to that call is that question is stating the obvious of doubling down on a message of the federal government has declared an end to the public health emergency. Like that's the top line message. And it's really thinking a lot about getting that out there because those of us that are in, like my organization, Health Law, is wonky. We're following it on a week-to-week, daily basis sometimes, but I'm not quite sure folks that are reading the paper and otherwise know that. And it's really having, and maybe this is what you're saying, Chachi, the public health emergency is ending. We're through the pandemic, but this is what this means for you in terms of your health coverage. And still going back to Zach's message is, and Kathy's message is reaffirming of, and if you have Medicaid, go back to DHS. It's not so much go back to Pennie and reevaluate your coverage. That's a message of the public health emergency, or not public health, but in October, that's a new message than we've had before, right? Because we do want people to think about the kind of coverage that they've had through Pennie in October and say, maybe because of this public health emergency, you're going to rethink your coverage. But I think that I'm struggling here and just reaching out to your call, Commissioner, of that's my take of top line messages.
Yeah, no, I think that's very fair, Laval, and it's something that, I mean, we too are looking at it separate from Pennie in the PID world on what kind of information we can get out surrounding what the PHE and will mean and when you do it, because it's such a fluid situation right now, but we also know that it has an impact on potentially planned benefits in some cases on what may be covered. So it's certainly one that we're talking to within the administration and through this conversation as well, in trying to have the most effective and ongoing outreach opportunities that we can. Anybody, any additional thoughts? Or Laval, I don't mean to cut you off if you had an additional thought.
No.
Anyone else? Then Zach, is this the end of the Chachi slides, or is there another one before we go to Dwayne?
I did have an update real quick, Commissioner, on just the webinar that we held already with MCO and QHP providers. But I will say, Laval, that I've been thinking of our at least advertising and message of more of an NPR informational type of message, the brass tacks, as opposed to more idealistic or super creative advertising. Really just keeping it down to the bare bones of what the message should be. So I appreciate you saying that. For our webinar was held back on April 25th, and again we covered a basic overview of what the PHE is and what must occur, kind of our phased communications approach. This was both in conjunction with DHS representatives, various resources that are available right now, what we're doing and putting together for our toolkit, introduced Pennie to the MCOs, what Pennie is, the coverage opportunities, and then what is needed from the MCOs, and then what the MCOs may need from us. And we distributed a survey to them at the end of the webinar, really asking for to establish a point of contact, what types of member outreach that they were planning, provider engagement, and different materials that they would need from us. And we have more webinars, at least intended, to have in the future, just so we could, reestablish timelines if it gets extended, have more direct communications with their point of contacts, so that we're not speaking to, an entire organization. We're really focused on, somebody that can, pass along the information or bring it back to us. So just wanted to give an update that we've, started that engagement now and plan to continue it. And I think that concludes the Chachi slides, unless there's any questions.
Any other questions before we move on from the Chachi slides? No? All right, now we're to the Dwayne slides.
Is that what we're going to call them from now on, the Chachi slides? I like it. Good afternoon, Commissioner, directors. Just want to spend a little bit of time talking through some of the things we're working on in the tech and ops side to support the unwinding of the PHE. So I believe previously we've discussed the auto eligibility capability, which, just as a reminder, will take households that are transferred from MA and CHIP and run eligibility for them. And then we're going to include that information on the welcome notice that we send out. We think that'll enrich our outreach efforts, hopefully bring a little bit more attention to that document and get some better results. Unfortunately, kind of rather late in the testing window, we did find a few issues related to income data so we delayed the rolling out of that functionality. Basically, at a high level, those issues were, in some instances, we weren't getting all income types in the account transfer. And then in others, there were basically a doubling or the income was being sent twice over to us. So both of those would have had pretty impactful impact to the APTC and eligibility. So we decided to delay that implementation. Thankfully, the DHS team was able to quickly put together a remediation plan on those. And we expect to be able to turn that functionality on here in late June, which will give us some experience with that new processing prior to the higher volumes coming in, assuming that the July 15th end of PHE trigger holds. Also, we are looking to develop some additional QLEs or chains from existing QLEs. I won't spend too much time on that, just because I know that those are going to be a topic of conversation based on the policy that we're putting forward. But assuming that we're able to get those things approved, then we'll quickly take action on those requirements that we've been developing. Also, we're planning on running the periodic data matching process monthly, so we can address the appeal volume on the MA side. Basically, I think Kathy touched on this earlier. If a member or a MA recipient is denied, they have a certain window of appeal, and once if they do appeal, then they are reinstated. So in the case that they would have come into Pennie's front door and enrolled and then been granted an appeal, there's a possibility that they would be doubly covered. So we'll be running that matching process on a monthly basis instead of an annual basis, so that we can address that appeal process that MA has. We are also coordinating with our vendor Get Insured to prepare for subsidies either being expired or being renewed. We're working through that timeline with them just to make sure that we're covered if those subsidies are extended or if they are not. So a lot of tactical planning with them has been going on. And then on the staffing side, we have established a new outbound calling team. Previously, certainly if we had to perform outreach to customers on a one-off basis, or if there was a cleanup or small outreach that had to be performed, we did that. But now we have the ability to do full-on calling campaigns, and we've been using that team to perform outreach for other programs like Path to Pennie or some other large outreach efforts. But that's important for the PHE, so we've been getting that team ready. And then also, we've been working with our vendor to make sure that we're going to have the right team, the size of the team. Normally, when we ramp up, it's closer to the open enrollment time. And of course, you know, that volume of CSRs depletes over time through attrition throughout the year as call volume and demand, you know, dictates. So at this point, we've been talking with them of what would it take to ramp up several months earlier than we normally do to make sure that we're prepared for the volume of both the account transfer population, but also any of those procedurally terminated folks that happen to call us. So that's a brief summary of what we've been doing, both technically and operationally from a staffing perspective. Any questions for me on any of that content?
Thanks, Dwayne.
Sure.
Any questions for Dwayne? No. Okay, so we've reached the time in the agenda from a time perspective that we were going to break. But we do have a couple significant PHE items, including potential votes, that I think will take a significant amount of time. What I don't think will take a lot of time is a discussion of the family glitch comment letter. So unless there's objection, I want to pull that agenda item up. I think we can dispense of that quickly and then break to come back to more of the full conversations that I think we're going to need about some of the PHE policy perspectives or policy options. Are there any board member objections to moving on to the family glitch now, taking the break and then moving it back to the agenda?
No.
Very good. Hearing none. Zach, let's jump into the family glitch letter and go from there. So I don't know if that's Zach or John, but jump right in.
It is John. Thank you, Commissioner. John, take us away.
Thank you, Zach, and thank you, Commissioner. If you could just flip to the next slide, Kelsey. In all honesty, I think you all know what the family glitch is, but at a very high level, it was caused by an IRS interpretation of the Affordable Care Act and some subsequent regulations. Essentially, it dealt with the affordability test, or how an employer's plan was determined affordable for an entire family. The contribution rate, if there was a contribution, if the employee must contribute more than 9.5 of household income towards premiums, towards the individual rate, even if the family rate was in excess of the 9.5 contribution rate. Essentially, the Internal Revenue Service, interpreting the ACA previously, in earlier parts of 2010 to 2014, in that range, interpreted the Affordable Care Act to bar those family members from coming onto the exchange and buying insurance through the exchange using tax credits and cost sharing reductions. The IRS has undergone a process to essentially reinterpret its previous position and to promulgate a new regulation that would fix this. This new regulation does essentially three things. First, it changes the affordability test. The main change in that is it creates two tests, one for the employee. It still will look at the employee's contribution rate against the employer's cost for single employee coverage. But then it will look at the employee's family rate at that same contribution rate to see if it exceeds the 9.5. This would essentially open the door for family members to not have to purchase the family plan if it exceeds 9.5 and come to the exchange, even if the individual still has to buy coverage through the exchange. The other two things this proposed regulation does, in a nutshell, is it revisits the minimum value as defined by the ACA. If an employer's plan does not cover at least 60% of the total cost, it doesn't meet the minimum value test. The IRS had previously interpreted this to extend the coverage to employees and family members. It did it through a mishmash of regulatory provisions. Essentially, this current packet rescinds all of those and reissues it to make it clear. When it comes to the minimum value test, it's not really changing anything. I think it's clarifying language. The third part of the proposed regulation really deals with rebates from premiums. So a premium rebate that occurs, a premium refund, that occurs in a subsequent year, there's no accounting to go back and determine whether it affected previous APTC or whether it affects APTC in the current year. None of these provisions are terribly controversial. I don't think they are, at least. I guess I'm going to find out in a second. Pennie's proposed, and Kelsey, you can flip to the next switch here. Pennie's proposed or ask of the board is to authorize Zach, or authorize Pennie through Zach, to submit a simplistic comment to this regulation, first supporting what the Internal Revenue Service is doing, but with one caveat, and that is that they do it quickly. Currently, the regulatory response period is open until early June. And then on June 27th, there'll be an Internal Revenue Service will have a hearing on this regulation. Because of that, there's some concern on our part that the longer they take, the harder it is for us to operationalize for next year. So the comment would be simplistic. We're supportive, but please do it as quickly as possible so we can make sure this is operational as quickly as possible. That's really our ask, is for you to authorize Zach to submit a comment of that nature. I will pause and take questions. And then if not, I will turn it back over to the commissioner.
So any questions about submitting a supportive letter on the family glitch reg? I will say that we at PID have already submitted ours. So with that, I guess then I will look for a motion to authorize Pennie to submit a comment supporting the IRS's reg as outlined by John. Do I have a motion?
So move. This is Laval.
Second, this is Tia.
All in favor?
Aye.
Aye.
Any opposed? Opposed? None. Motion carries, and unanimous vote. Thank you all. Thank you, John. We've just made up 20 minutes, I think. So with that, let's break until 1:45 with the plan to come back and immediately go into the discussion of PHE policy proposals. So I'm going on mute to grab a quick snack, and hope you do too, and I'll see you in 10 minutes. Bye. All right, the time looks like 1:45, so I think we can get back and get started again, despite being the 10 fastest minutes of my life. I was able to grab a cherry Coca-Cola Classic, so I'm feeling good. With that, let's roll into the PHE policy proposal, Zach. Uh-oh, Zach, did you
Thank-
not make it back?
No, I'm back. I was waiting to stop laughing before I got off of mute.
That's all right. Some of us needed an 11-minute break, I guess. Well, just bring us into the policy proposals.
Certainly. So we have two proposals for your consideration today. Both are associated with the loss of minimum essential coverage SEP and are specific to trying to make it easier for consumers kind of lost in the shuffle, confused, maybe, falling through the cracks. They're all aimed at trying to, make it a little bit easier to help and serve that consumer through the process. So let me go through them in detail in a second. We did put, this did come out of, not guidance, but suggestions from the feds around different flexibilities available to states, to state-based exchanges, in the interest of doing just what I said, trying to make the transition as not necessarily easy, but as flexible as possible, in the interest of trying to catch people moving from one program to another. So the first proposal here is associated with the length of the SEP, and it is to extend the loss of MEC SEP to 120 days, effective the month in which the PHE unwinding period begins and terminated on the last day of the unwinding period. The policy goal here is to provide for a seamless transition for or an easier transition for consumers losing coverage during the PHE unwinding. It gives consumers experiencing loss of coverage additional time to access it through Pennie, to access coverage through Pennie during what is a, very high volume and unprecedented event. We think is in service to the strategic goals, objectives that the board adopted in the last board meeting, where the board adopted goals to prepare for the unwinding of the PHE in a way that minimizes harm. There was a goal that was adopted associated with advancing policies and practices that reduce inequities for vulnerable populations. Some benefits here include minimizing the gap in coverage for those experiencing a loss of coverage, for those who experience a loss of coverage. The 120-day SEP would be longer than the DHS reconsideration period. So if someone is caught up in the 90-day reconsideration period and ultimately ends up on the outside looking in, uninsured, they would still be able to come to Pennie and get covered even after that concludes. Some challenges associated with this include that it, obviously differs from current practice, is a longer period for folks to come in and get covered, and that there's work associated and operational challenges associated with creating a temporary change from current practice. So a little bit more about the proposed approach before we talk about the stakeholder feedback. This would extend the loss of MEC SEP from 60 days to 120 days for the duration of the unwinding period. Option would be made available starting during the month in which the PHE ends and would sunset after the unwinding period is complete. So tentatively, that is January 31st, 2023. the 120-day SEP would be granted to customers starting in the month in which the PHE expires through the last month in which DHS processes customers during the unwinding period. The example here is if the unwinding period ends on January 31st, an individual losing coverage on January 31st would have 120 days from that day to enroll through Pennie, but an individual losing coverage in February of 2023 would have 60 days to enroll using the same SEP. And Heather, I think you're off of mute. And I took care of that. Any questions about that before I get into the feedback on this? Okay, moving to the next slide. We did get this out to stakeholders, and the stakeholder feedback was by and large supportive of this policy. The majority of stakeholders, including insurers, brokers, and assisters, supported the policy as proposed. We have some quotes here. A positive mitigating effect on unintentional coverage losses or gaps outweighs the potential negative impact of any customer confusion. Another was low income or low English proficiency populations need more time, more help and time. In the support, one of the supporting insurers did request to require documentation for those reporting loss of the SEP, loss of MEC SEP after day 60. And we touch on that a little bit in our recommendation. Like I said, the majority of stakeholders supported, but there were some people, some stakeholders in opposition. The opposition was mostly concerned about confusion caused by deviating from the current rules, as well as the overlap with the busy OEP system, and some felt that the current 60 days was sufficient. And there was a request, at least one request, that the extension be limited to only those losing Medicaid due to the end of the PHE. We got that feedback on both of these policies, and there, think there's a lot of merit because this is associated with the end of the PHE. There's a lot of merit associated with trying to do that. Unfortunately, that's not allowable. Because we can't carve up the loss of MEC SEP and make it specific, one way for some groups and another way for other groups. I think that violates the equal protection clause, but I'm not a lawyer, so I should have just said that our counsel has told us that that is not allowable.
Very good.
So what does that mean, Zach? It just means that the entire, for this period of time. Would you say that again? I'm sorry, I didn't follow what you said. It's not allowable to only make it.
We can't make it specific to a subset of those who fall under this loss of MEC SEP. If you're going to make changes to categories of SEPs, like loss of MEC, which loss of Medicaid is falls under, you can't make policies specific to just the Medicaid population. You have to make it to anyone who is eligible for this SEP who loses qualified MEC.
So anybody that loses a job would have 120 day, loses a job that gave them medical coverage would have 120 day SEP?
Correct.
So this is Frank, just on that last note, Frank with Capital Fernandez, sorry. So does that mean that we're sort of broadening or expanding sort of even the more traditional SEPs by potentially doing this? And is that due to the need for, whatever reason in law or reg to treat everyone equally? Because it seems to me that the PHE in and of itself is sort of due to obviously unusual extenuating circumstances. So I guess I'd like to hear a little bit more about that.
Yeah, and John, do you think you could jump in and talk a little bit about why we can't split it up, please?
Absolutely. So the federal government is actually authorizing us to extend this SEP from 60 to 120 days. It's their regulation. And I agree with their assessment of it, but essentially anyone who loses MEC falls under the same section of the same subsection of this one part of the federal code. So Frank, to your question, we're not extending the jet to their like 19 categories or 17 categories of SEPs. We're not extending we're only extending the one, but it's everybody that hits that class. It's anybody that loses MEC because that's how the regulation is currently written. It doesn't parse out reasons per se for losing MEC. It's just you lost MEC. So we have to treat all the people in that category the same. We can't differentiate between them for a myriad of legal reasons. But the concept, but to your question, we're not changing any of the other, I think it's 16 or 17. It's only that one for this period of time. I think I answered your question. If I didn't, let me know.
No,
Frank, did he answer your question?
I believe so, yeah, thank you.
Very good.
So
I
we're
see
also-
Laval's hand up. I see Laval's hands up. Laval?
Well, I'm leaping to just reinforcing something I was thinking about before. Should we go ahead and adopt this as a board? And hearing the discussion so far, I'm in favor of it and supportive. It circles back to this message of the impact of the end of the public health emergency. While many of us have viewed it through a Medicaid lens, this extension of the SEP for loss of MEC just again enforces that point. It's tied certainly to the PHE, but it has so much ramifications beyond the Medicaid population.
Good. Any other thoughts, questions?
But doesn't include for non-payment. If you lose your minimum essential coverage because you didn't pay your bill, does this open up a new window for you?
You mean you didn't pay your bill for coverage through Pennie?
Yeah.
I don't think that qualifies. Hannah, are you
Zach,
trying to answer the question? Yeah.
Yeah, sorry. Paul, it's a good question. Loss of coverage due to non-payment of premiums is not currently, existing rules make that you're not eligible for the loss of MEC SEP under 155-420 D1, which is the provision we're talking about here. So those folks are currently not eligible for the SEP.
Any other thoughts or concerns or support?
So
Well then, go ahead, Zach.
can I just go through the recommendation real quick, Commissioner?
Yes. Yep.
So the recommendation on this one is to adopt as proposed, which would be to extend the loss of MEC SEP to 100 days during the PHE unwinding, because it will help more people get covered. To the question of limiting or trying to document after a certain period, we can't systematically put that into place. By the way, I was told that I said 100 days. I meant to say 120 days. So we can't put that systematic check in place to have it trigger something else after 60 days. But we did want to call out very specifically that for the account transfers that come over for medical assistance, that is an automatic documentation of their loss of MEC and triggers it automatically. So that doesn't cover everybody, but for the folks that come through the happy path, we will have verified documentation of their SEP. As we discussed, we cannot restrict extension to only certain types of loss of MEC. And to the concern about overlapping with open enrollment, We are concerned about how the PHE will overlap, and are concerned about the challenges associated, in particular with people who are losing coverage in November and December, because they'll be in a position where they need to sign up for coverage in 2 plan years at the same time. That is, of course, something that happens every year, but not nearly at the volume we will see this year. So we are concerned about that. But we also think that this SEP will actually help, and give kind of be a safety net for people who may not have gone through that process the appropriate way because of the the complexity and the confusion associated with it.
Very good. Thanks, Zach. Any other questions for Zach? Well, the recommendation to me makes sense, given we're about to go into such a potentially challenging time when the SCP or the PHE is officially wound down. But with that and not hearing any questions, I think I will ask for a motion or entertain a motion.
Actually, Commissioner, this is Frank Fernandez again. So Zach, can you just address the, I mean, I think it's sort of self-evident to some degree. However, would like to hear a little bit more, if you wouldn't mind, with respect to the extension to 120 days versus 60. It's just creating more time, more opportunity, correct?
Yeah, it's creating more time. It's creating just more bandwidth, more availability for individuals who don't smoothly come over through this process. So we've talked about the different categories of folks. We think that we have a better chance of getting people through who come through the account transfer process. We think we have a better chance of getting them through and covered and enrolled. But there's still a possibility that group through that happy path are confused about the process, aren't getting the communications for whatever reason, don't get the message and just need more time to complete it. And then there's the populations that don't respond to DHS. And we won't be able to get their information to conduct direct outreach until 30 days after they lose coverage. And it may be that they don't figure out that they lost coverage, that they didn't, they're unaware that they lost coverage for a prolonged period of time. And we think that those are a couple reasons. We think that the burden associated with the volume of people coming through during this period is going to be significant. There's only a certain number of brokers and assisters across the Commonwealth who can provide enrollment assistance. We will do our best at the call center to staff up and accommodate incoming interest and assistance requests, but I worry about the system being overburdened, overrun, and people not getting the enrollment assistance they need in a timely manner. And this will help with that as well. Did that address your question, Frank?
Yeah, thanks.
Any other questions for Zach? Well, then now we will look for a motion. Does anyone want to make a motion?
This is Tia. I so move.
Is the motion?
I'll second.
Second.
I'll second. Okay.
Whoa, time out. Tia, what is the motion? Is the motion to adopt the recommendation as put forward, or is there a different motion that you wanted to make? I'm sorry.
Putting forth the recommendation to adopt the staff recommendation as proposed.
Thank you, Tia. Seconded by Laval. Any questions about the motion? My intent is to do this via voice vote and not a roll call, unless otherwise asked. So I will go ahead and conduct the vote. So all in favor?
Aye.
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 Any opposed? All right, Zach, let the record reflect that it's an unanimous vote of the board in support.
Yep, and Commissioner, I think we should acknowledge that Antoinette was not able to join and sent her proxy vote to Laval, something that only recently came through.
Okay, we could do that. And Cheryl Kashuba gave me her proxy, so she's also a yes. All right, with that, Zach, we'll move into the second policy proposal.
Great, thank you. So this is a proposal that goes along, is still related to the loss of MEC SEP, and it is very specifically about providing people who come in and sign up during the SEP, which now will be 120 days, the ability to choose coverage start dates, which can either be the first of the month following plan selection. Well, I'm reading these backwards. Sorry. It can either be the first of the month following coverage loss event date. So we heard from Kathy, people lose coverage at the end of the month. So that would be the first of the month after when they lost coverage, or the first of the month following plan selection, which is the current structure for how this SVP is set up. So if you sign up today on May 10th, your coverage begins on June 1st. So this would be giving the consumer the option during the PHE unwinding period to either go back to the first of the month following their coverage loss date, or the first of the month following their plan selection. The policy goals are similar to the last one, ensuring that people have the ability to move from one program to another, also ensuring that they have continuity of coverage for folks that are, again, confused, caught up in the hectic time and fall through the cracks. If they need the ability to have their coverage going back to when they lost coverage, this will enable it. And then, again, benefits include providing for continuous coverage and limiting to loss of MEC QLE will ensure those with access to this option were previously enrolled in coverage. So this would be available just to people who were previously enrolled, and not to anyone coming off the street. Some challenges associated with this include differing from current practice, as well as the fact that we'd be treating this SEP different from all of the other ones. I'll just add that I think when we thought through, the goal of trying to minimize harm through this transition process, through this hectic time, I think we've been pretty concerned about the folks, most concerned about the folks that aren't aware that they're losing coverage for whatever reason. And that the first time that they learn that they did lose MA is when they go to schedule something, or they go to fill a prescription and they're denied at that point. I think it's, the intention there is to give people who always intended to have continuity of coverage, but experienced a gap because they were unaware, the ability to do so. So the proposed approach is to provide consumers experiencing a loss of MEC SEP the option to have the coverage effective date, that is the first of the month following an event date, while enrolling in coverage after the event date proposed, provided they are in the SEP window. I've already gone over this. And then options would be available starting during the month in which the PHE ends and would sunset after the unwinding process is complete. So if the unwinding process ends on January 31st, this policy would sunset. So any questions there? We also have stakeholder feedback on this one as well.
Why don't you go into the feedback, Zach?
Sure. So the feedback on this was more mixed, for sure, than the previous one. And I would say that the majority of consumer advocates, brokers, and assisters supported, and 2 of the 7 medical insurers supported. The primary reason given was for the need for seamless coverage. Some quick quotes here. It's a huge benefit, generous and useful, very helpful with this particular client base, gives a bit of reprieve and needed flexibility. Crucial at the end of the PHE because many MA enrollees might not realize their coverage has been terminated for months. Another comment spoke to choice of retroactivity is critical for the poor and working families who will be hit the hardest. Consumers currently in treatment need the option of retroactive coverage, while consumers who do not have additional income and do not have health needs are unlikely to be able to afford back premiums, which would cause them not to complete enrollment. One commenter said, while this could open itself to adverse selection, I believe it is fair based on uniqueness of the overall situation that created the PHE. And then lastly, we thought it would be worth highlighting that one insurer did who opposed said they would be in support if it was only limited to those losing Medicaid during the PHE, not to all losing MAC. So again, we can't change that, but I thought it was helpful to share that. In terms of opposition, 5 of the 7 medical insurers and a few brokers and assisters opposed. Primary concerns were risk of adverse selection and customer confusion, abrasion due to multiple months of premium due right away and difficulty accessing services prior to enrollment. Some of the quotes we pulled out to share are as follows: allowing for retroactivity typically requires more operational support and can create customer confusion, especially in the billing and communication processes where members will be charged multiple months and or move straight into a past due process if only pay for initial month of coverage. May face difficulties in paying even a heavily subsidized premium if they need to pay back several months at once. Another quote is, absent some catalysts related to a pressing need for medical services, there's little or no rational basis to select a retroactive coverage date. And then an insurer noted potential for operational complexities with retroactive enrollments into the prior plan year. So we did, on the following slide, we have a couple things. One is the recommendation, and the other is we did feel like some of the concerns associated with customer confusion or abrasion that we were not able to, may be addressed through showing how it would work and really reinforcing that this is a choice of the consumer. It did seem like some of the feedback assumed that the only option would be retroactive coverage. And again, that's not the case. So before I get into the recommendation, below it, we just have an example for your review. And that's someone who loses Medicaid medical assistance on August 31st and starts shopping in October of that year. So in the second month after they lost coverage. If this were to be put into effect, this is an illustration of what it would look like. This isn't the final language. This isn't the final mock-up, but a couple things we wanted to show is first is that the default would be for first of the month following shopping. So this would pop up, and what it would show is that it's pre-selected as next available date, which would be November 1st. The comment would say you have options. Please choose a start date for your new coverage. It would be pre-selected at the next available coverage date. They would have an option below that to go to the earliest start date, which would be back to September 1. And here in the application and in subsequent messaging and outreach, we'd want to make sure that we are very clear that if you go with the retroactive coverage start date, we'd want to make it very, very clear that for that to go into effect, you have to pay all of the premiums associated with going backwards, which in this case would include premiums for both September and October. So before we go into the recommendation, are there any questions about the proposal, the feedback, or anything else?
Zach, this is Antoinette. I just wanted to let you know I'm here.
Oh, hi, Antoinette. Welcome.
So Zach, this is Frank Fernandez with Capital again. Just a question. You know, in terms of, you know, a situation where someone's looking at these prompts and going back to a previous comment or earlier comment that you shared in terms of feedback, the only sort of plausible reason that folks would likely choose the second or the earlier date is because they've likely incurred services during sort of the coverage gap, so to speak, and let's just assume have done the math quickly, or at least have given it some thought, and then choose to pay the premium going back, right? I mean, otherwise you're paying for coverage that you, I mean, wouldn't really need. Is that fair? And is that how you guys are thinking about it?
I think it's fair to say that someone who's going to go back and pay the past due premiums for the earlier coverage start date is more likely to have incurred claims during that period than someone who is not. So yeah, I think that's mostly fair. I think, as I said, I think primarily we're worried about people who only learn about loss of coverage at point of service and therefore are in a place where they have to pay out of pocket and are pretty interested in figuring out a way to rectify the loss of coverage. That doesn't mean there aren't circumstances where that, where that's not the case, but I think our primary concern with this option is really trying to make it so people who get lost in the shuffle have an opportunity to get to a place of continuity of coverage.
And Zach, I guess another example is like if I auto pay my maintenance medication. So I was disenrolled as of the end of last month. Maybe early next month is when my 3-month renewal was up. So I get to the pharmacy and that's where I found out that I don't have coverage anymore. So I wouldn't have incurred a claim during that period, but this will allow me to go back and pay for last month and this month to get coverage for the prescription that I want to pick up. So I guess it isn't only people that would have incurred a health expense over the past period of time. It could be those that prospectively know that they have a cost coming up and or that are at the pharmacy at the same time.
I agree with that.
Zach, this is Tia. I have a question. Is the only option to go back to the earliest start date? Even looking at this example, I would think that an option to enroll as of the first, retro enroll as of the 1st of October would be feasible for folks.
So we did not propose that. We did think about that, Tia. We were a little, we expected that there would be opposition to this, that there would be adverse selection type arguments, and that having someone be able to pick in between, would kind of bolster the argument that someone is only kind of trying to pay for the coverage that they need. And so that's why we landed on the kind of all or nothing sort of approach, which is if you want retroactive coverage, it has to be back to when you lost coverage, or you can go with the option of just getting coverage going forward.
So this is Paula. Before the public health emergency and magically on February 1st, it's all going to revert back to the way it was, where people went through a redetermination process, their Medicaid expired, they did what they had to do or they didn't, and we processed all this kind of stuff month in and month out. What we're saying, both the proposal that we just approved and this one, is a concession to volume. And so, you know, the first one is a little bit easier to kind of get your arms around and say, okay, it's, you know, there's no adverse selection, there's no particular economic disinterest, there's a lot of operational things from a carrier perspective, and will kind of give a head nod to this notion of volume. But, you know, what is it about the volume constraints or that make this necessary, or that somehow make it different, that people, what they would have done or what they're going to do in February at an individual level, each person by person, is no different in October and February. And so I'm having a hard time understanding why we're carving out this period and giving increasingly, you know, advantageous terms to folks during this period, when prior to the PHE and after the PHE, we're going back to the way things were.
That, I mean, I'm happy to weigh in, others can as well. I think a couple things. One is the volume. There is a volume concern here. But I think more important, specific to this policy for me, Paula, is the people who lose coverage who are not aware, and always have the intention and only ever learn that they're uninsured at the point of service, and so are in a place where maybe they have to pay out of pocket for whatever they're doing, but really want to get to a place where they actually have a place of continuity of coverage.
But isn't that going to be the case in February, Zach? How is that going to be different?
I mean, what's different is that we'll be on the other side of the unwind of the PHE. So we're going to be in a circumstance where we've kind of returned to normal operations. And I don't, you know, it's not that, I mean, you know, the concern will exist in February and beyond. And I think there's potentially an argument to make this policy available in perpetuity, but I don't know if you're making that argument.
I mean, the issue is that we're thinking about this. The only thing that the PHE did was put a halt to the standard processes of redetermination vis-a-vis this, right? I mean, it did a whole bunch of other things, but vis-a-vis what we're talking about. So all we're doing is getting redeterminations back on a regular cycle.
Not for
and so, but we're making, you know, we're talking about sweeping concessions, especially now that we have to wrap in all of the other folks, you know, in the, you know, loss of coverage SEP. And I'm just, you know, uncomfortable. I don't know how others, you know, feel about it.
So this is Antoinette. I mean, I would just say we deal with this population a lot. And I think even now we see people, I mean, outside of the public health emergency, who've lost Medicaid coverage, and they don't realize they've lost Medicaid coverage until months and months down the line when something happens, because they're going to get treatment or something, they're sick. So I just worry with the volume of people that are going to be shuffled around with the public health emergency, knowing that this population may have less experience of the marketplace and may just miss that this is happening, that this is a really important protection for folks to have, because then what happens in February or during open enrollment, they're just going to be sicker because they weren't able to get coverage then. So to me, I think it's a really important protection to get us through the huge number of people that are going to be making a transition. And we'll do the best job possible, but people are going to get lost. It's just inevitable with that large of a volume and knowing this population from past Medicaid interactions.
Laval, I know you had your
Texas.
hand up and then took it down. Did you have something to add or a question? Sorry, I didn't see it right away.
Oh, no, not at all. Not necessarily to add too much more to what, it's a different point than what Antoinette noted. It's significant that a majority of the brokers and assisters are supporting this provision. I realize that a number of insurers are hesitant. Not all, but a number of are. But in terms of brokers and assisters supporting it, I think because they are at the front lines and will be at the front lines in dealing with volume, it's significant that they're saying, "Yep, we support this approach. We realize it's much different and time limited, but all policies and practices that can help us get through the end of this calendar year and this overlap with the OEP, I think helps."
I see a comment from Alexis or a question from Alexis.
Yeah, I think just weighing in on a bit more of a principle of, what we are as a governing body. I think that if, that there is a line that I guess I draw in my mind on what an insurance exchange board should be supporting. And so if I look at, what the definition of insurance is, I think this type of retroactive coverage no longer is insurance. And so when I thought through the two proposals, looking at, the extended SEP, well, and let me say that, an SEPs are there in general to provide that sort of cushion for things out of the control of, of the person, of the potential member, of the constituent. I just think that, I tried to balance, I just telling my fellow directors how I'm thinking through this, try to balance I do know that there's additional volume. I could see my way clear to say, let's extend that special enrollment period so that there is time to, complete the outreach and hopefully cycle through the thinking process to actually get enrolled in coverage. But where I stop short is, starting to become something other than an insurance exchange and provide that retro coverage. Now, do I wish there were other things that we could do, that, there was access to other funds to serve as a cushion to cover excess claims, things of that nature? I do, but it's like, there are a lot of other constraints that I think we're dealing with here. The 6 months to process, the, no sooner than 2 months notification, lots of different things we're trying to deal with. I just don't think it is, enough to cause me to want to cross that line into being something other than an insurance exchange.
Yeah, Alexis, I'll respond to you. That's a good point. I understand where you're coming from and respect it. I think and it's a powerful point of it doesn't feel like insurance. I suppose the counter that's in my mind is about that the population that's affected here is, and it's tied to the volume issue argument, but it's this population that's not necessarily able to get to the state Medicaid agency for reasons that may not really be their fault. They're not able to get to Pennie because of volume that we're concerned about and staffing. And they're incurring some expenses, and they'd like to have that continuity of coverage. Not everybody will go backward. A number may look at that helpful example and say, yeah, I'm going to take the next available date. But that's where, to me, I think in this extraordinary period with PHE lifting and to get through it, I still come out of it's necessary. I will say that this may be a situation where I think in my tenure, we don't have a lot of split decisions in votes. Usually we're getting toward consensus, but sometimes that doesn't happen. And we respect each other, but we just may have a split vote. I'm not trying to end the discussion and say, let's call the question and have a vote, because I think comments like Alexis's is important, and I'm interested in hearing and open-minded about it. I just wanted to add that comment.
Other thoughts or questions?
Yeah, you know, I know Cheryl's not here. Alexis is also kind of in a different circumstance where they're more tied on the provider side as well. And I know at Independence, we're also in a situation where we have at-risk providers, right? And, you know, so we're making a decision that we're going to accept, you know, costs on behalf of these members that providers may not get reimbursed for because they didn't have an opportunity to help manage the patient. So it's a little bit of a kind of a double leap here that we're agreeing to undertake, you know, just kind of piggybacking on Alexis's comment about our role as insurers. You know, we have risk-based arrangements with providers that all of a sudden we're saying, oh, by the way, you know, we're gonna agree to accept liability of, you know, unknown amount that you are going to be powerless to do anything about.
I mean, a couple pieces about, I appreciate that the statement about our role as insurers. I am hearing that, but I'm on an exchange, a board of a state-based marketplace exchange, and it's not. I don't necessarily know if we're really that far of an outlier from other exchanges, but this is something that I'm assuming is contemplated within the federal rules for how you operate an exchange, the federal marketplace, the state-based marketplace. So I'm not quite sure where that. I heard what you were saying of it. It seems like this isn't insurance, but it is insurance. We're not operating really outside the lines of our authority as a state-based marketplace. It's not that.
When you elect to cover somebody after services have been rendered, it's like, oh my God, my house is burning down. I need to quickly get homeowners insurance. That's not insurance.
Yeah, I guess, Paula, what are some scenarios where I guess what you're talking about, med management, prior auth would be applicable, that you would otherwise manage the patient? Because as I think about it, if we're talking about ER, you wouldn't have any ability to prior auth. No surprises. You're on the hook regardless of where that person decided to go. So if I'm trying to retro because I had to go to the ER, the company wouldn't do anything differently than if they had the person from the beginning, because they couldn't help manage that. Now, I guess maybe we're talking about elective procedures that when a member tries to schedule, the question doesn't come up about whether they're insured or not. But I don't know that would happen. And certainly in the perspective of giving estimates required under the No Surprises Act also, like that would raise a question. So I guess I'm trying to figure out what procedures we think would have medical management that the insurer would miss out on because someone was able to go back.
Well, I mean, it's also things around, just kind of regular, med management that somebody might have been doing something differently. So I'm trying to think of where there might be an incentive payment, so the fee schedule is X, but there are additional payments that are made if the provider does Y, right, in terms of managing that patient. But they never get an opportunity to do that because, they didn't know the patient was covered under that arrangement until after the fact.
This is Antoinette. I mean, I guess for me, it just goes back to the fact that we are talking about major disruption at no fault of the consumer, right? And I think the number of cases where we're going to find people in these situations is very low compared to the value of making sure people have continuous coverage so they don't get cut off, they don't lose their doctor. They're also, at the same time, many of them have never had private insurance, or they haven't for a long time, so they're learning to navigate the system. So this is another protection. And I just don't think, and the insurers can correct me if I'm wrong, that this is going to be such a huge problem that it's going to bankrupt anyone. And I would also believe that this population is also going to be getting ARPA subsidies, a lot of them probably 100% coverage. So I just feel like it's really important when we look at goals of equity, we know this population, it's important to give them these protections.
Hey, Zach, are you aware of, I know you have regular meetings with other exchange executive directors. I'm not aware of how other states are approaching it. Do you know any that are considering it or that have gone down this path? I guess considering may be confidential, but are there public information that you could share in that regard, or of what's come out of CMS?
Yeah, certainly we know of states that, I know of states that have done it. When I was the director in Rhode Island, we allowed retroactive coverage start dates. And I think they still do, but I don't know. We definitely know, as it relates to the PHE, that other states are considering this at the very least, if not doing it. And, as I mentioned earlier, the feds made sure to highlight this as an option for kind of mitigating it. And I think one other thing to just bring in here is that most other states that have state-based exchanges are doing the unwind over a 12-month period. So we are a bit of an outlier as it relates to that. I think we have probably, anyone who's doing the unwind in a more compressed time period has more of a pressing need for something like this to mitigate the disruption.
Why can't the state put the member back on Medicaid coverage for the intervening period?
I don't want to speak for DHS, but I think if you're not qualified for Medicaid, you can't be enrolled in Medicaid.
Yes, that was going to be my response, Zach. If they're not eligible for Medicaid, we can't cover them under Medicaid.
So back to this. Oh, go ahead.
Oh, just a quick question, Lamal. Sorry.
No, go ahead.
Just as a follow up to that last comment. Typically, or kind of traditionally, when there's a transition of some kind, and let's say someone's impatient, what have you, the previous carrier or whoever's whether it's a legal entity or governmental entity would be, accountable for continuing to cover that stay for continuity coverage purposes. Is that the case here? I'm just not, I guess, sure whether that would be the case or not. Does anyone know the answer to that question? If there were more sort of acute episode underway at the point of losing Medicaid coverage is, I guess, my question. Would Medicaid still cover that piece, or would it end when the coverage ended officially?
Great question.
I think
So
it goes right up until the point that you've lost the coverage. And while we have a continuity of care rule in the state, I think that's Act 68, that deals with continuity of care and obligation on the provider side. If Medicaid coverage ends on August 31st, it ends on August 31st, and it's not continuing past that September date. That's done. There's no way for Medicaid to pick that up. I feel like that.
If you're in the middle of a high-risk pregnancy, your coverage just ends.
Well, under high-risk pregnancy and under Medicaid rules, and that high-risk pregnancy, if you're like, hey, let's play that out in this model, it's not going to play out because the state has specific rules for women that are pregnant that they're not getting pushed off of Medicaid in this situation. Don't put that scenario into the picture because there's additional Medicaid coverage protections for that category of Medicaid individuals. In fact, that's actually, it's not ending at the pregnancy. It continues on for another 12 months because Governor Wolf has said, yep, we're keeping that group on. So that category, I use another example, but in that category, if you're thinking about that in terms of the application here, don't.
About somebody in the middle of lung cancer treatment.
Paula, I want to jump in here for a minute. I think we have, as a board, not taken a vote that I think was not unanimous, maybe ever. And this one is certainly looking that way. And recognizing that we just extended the SEP for the future. I'm curious if there's a way to at least, so maybe it's not the full 120 days, but maybe we give people 2 months to retro to minimize the risk of adverse selection, but still also give consumers the benefit of this is a pretty unprecedented period with the PHE coming to an end, hundreds of thousands of people to be redetermined in an effort to minimize those that would fall through the cracks. Is there a way that we can get to a level of comfort that we are allowing them to retro their policy and come together as a board? And I would suggest we bring that back to 2 months, but would be interested in other thoughts. I know Cheryl, I have her proxy. Cheryl's going to abstain. So, the votes will go where they go, but to the extent that we could come up with something to pull us back together as the Pennie board, I think that would be in the best interest of the Pennie board and consumers.
Yeah, I appreciate that. We hear heartbreaking stories all the time about people who call begging for retro coverage. We just don't do it. It's not insurance, to Alexis's point, and it's heartbreaking. And I totally understand that. And we won't do it come February. And, we heard Kathy talk about, which I was really happy to hear, the extent of all the communication that was starting well in advance of people losing, potentially losing their Medicaid coverage. And that, again, starting in February, people are going to have to react to the communication that they're getting and, take some kind of action in order to maintain their, their insurance status, under one policy or another. So it's just, it's hard to square, making this exception during this period of time, because it's a radical thing to do. To Alexis's point, it's not insurance. And so, interested in other people's thoughts, Alexis or Frank, but I don't know how you square that, truthfully.
I gotta jump in on one piece about the concept of insurance. Medicaid, I know we're not talking about Medicaid, but as somebody that's a Medicaid practitioner who's devoted 12 years to representing folks in the Medicaid system, and its managed care contractors, Medicaid's retroactive. It goes back 90 days. So the concept of, insurance, this isn't insurance, is let's go within, I understand in the Pennie world, it's not retroactive. But for folks that are applying for Medicaid, it certainly is. It goes backwards. It covers folks that need that coverage, whether it's long-term care nursing home, whether that's all the other parts of Medicaid. It's always been able to go backwards. It's viewed as a protector, as a safety net for that population that it needs. I realize that it's very different for some on the call to hear, we're going retro. But for many of us in the Medicaid side, we've had that, and we're proud that Medicaid's been able to do that. I also realize this is extraordinary situation coming off of pandemic, where again, I still kind of circle back to the volume that's at play here, not recognizing that, yes, it's a precedent, but I'm not quite sure it's going to come along ever again, to be able to have retroactive coverage for this very limited window. Because it's extraordinary that this group really might not be able to, again, get to DHS, get to Pennie because of volume, incurring some medical expenses, and we're trying to minimize harm. And people just won't be aware that at times they've lost the coverage. And yes, it's a population that's, because it's the Medicaid population, it's disproportionately people of color, it's disproportionately women, it's disproportionately low-income people that are likely eligible for advanced premium tax credits. But we're looking for grace in this situation to allow that to happen.
I
Are there-
recommend we go,
Go ahead.
we vote and see how it goes. And if it
Who's
doesn't
talking?
pass,
I'm sorry.
this is Jessica this is Jessica.
Yeah.
So I was saying I would recommend we go for a vote. We can continue having the discussion. We see how the vote goes and then determine what could a modification be, or where can we get to a resolution. Do we need to come to a resolution before we vote the first time?
We don't need to know. My hope was that we could get to the public vote that's unanimous, and that's why I wanted to throw out the idea of coming together around maybe 2 months to retro. But I don't know that I've heard support for 2 months from those that may not be supportive of 6 months, or not, I'm sorry, 120 days. If that's more amenable to keep it at 60 for retro purposes. But as chair, I also recognize that if there's a motion to be made, I need to recognize and receive the motion. So while I would prefer to move together, the floor is open. Paula, did you have another comment?
No, I just had a question. What happens when this retroactivity crosses a calendar year?
It's
To retro back to December.
Yeah. Yep, retro back to December. It would be retro back to December for that month, and ideally we have a mechanism for auto renewing them into coverage for the following year, but it would cross plan years, if that's your question.
Say that again.
Go ahead, Paul. I think you cut out.
No, just say a sec to say it again. I didn't hear what he said.
Sorry. There's construction going on outside my window. Give me 1 second. Apologies, it's been quiet all day and all of a sudden it kicks up. So what I said is, what I was saying is that if your question is, would the retroactive nature of the policy cross plan years? Yes, it would. So if someone was lost their coverage on November 30th and is shopping in January, they could, under this policy, have the coverage go back to December 1st.
And they're going to have 1 month of coverage and then re-enroll? I mean, it's not, it doesn't, there's no continuous coverage between December 31st and January.
That would be the goal, to have them have, I mean, I'm not sure I agree with that statement. If they were enrolled in Medicaid in November and they only could sign up for coverage beginning January 1 or February 1, then that would be a gap in coverage, in my opinion.
No, I'm just saying that I don't know what you would retro them into, because the policy in December is not the same policy as the one in January.
Right. I think, the intent would be to renew them just like we renew everybody else.
I see another hand, I think, Alexis.
Yeah, just in terms of whether we call for the vote now, not having been with this board, since the beginning, I guess I didn't realize that, there had always been consensus on all the votes. And if we think that is necessary, for future board function, I don't personally believe we've gotten to a place right now where we're going to achieve that. And so I know we don't have a lot of time between now and the potential end of the PHE, but I do wonder if it is worth spending more time trying to find a common ground. Guess what I'm saying is right now, I still feel like I'm in a position to vote no. And if that is if that's a challenge to future board function, I don't think we should call for the vote.
Yeah, and before I recognize Laval, Zach, are there procedures for emergency meetings of the board? If the will of the group was to have a follow-up meeting just on this issue? I guess that's a Zach or a John question.
I mean, I can take it. There's always the ability to call out of schedule meetings. There is a process and procedure for it. And, I would offer a couple things. One is we need the ability to have this policy to operationalize it. And I would say, whether or not the PHE ends on the 15th of July or the 15th of October, we are now in the window, we're past the window by which we need to start actually having our vendor build this. And can make it happen. And, you know, if you guys want to take more time, we'll try and do what we can to operationalize whatever comes out of that. But I want to impress upon you, this is not something we can do overnight. It's something that we need the authority to have in place to operationalize it. And we can't, you know, we can't wait time to make a decision. And then I guess my other question is, what is with more time, what would change? What, you know, I'm not really hearing a proposal. I think the commissioner, an alternative. I think the commissioner put forward something that shortens the window of retroactivity, and it doesn't seem like that was well received. So I don't exactly know if what the path would be for getting to consensus. So,
and Zach, I think if the board were to delay a vote, I think I would ask that the motion also authorized us to technologically be ready while punting the philosophical conversation, so that if we do ask for a follow-up meeting in a couple of weeks after we would know when the PHE ends, that you have at least been given express authority to get it ready to the extent that the board votes to approve it. Because I mean, right now it's going to be a split vote. And I don't know where that lands, but at least to the extent that should it be approved, if we were to delay, I think you should be authorized to be going down that path. But all that being said, I see Laval, your hand is up. Want to circle back to you.
Thanks, Commissioner. I think I agree. Obviously, we all do. It's the proposal for retroactive coverage for 120 days. Is not going to get well received by everyone if we had a vote today on it. I mean, we might want to call for a straw poll just to see where we're at. Not necessarily go that way, but again, we could do a bit of a straw poll to see where folks are at. This is the other item I wanted to add is this is a challenging overall system. The state, the Commonwealth, has made a decision to do a 6-month review of Medicaid. They have up to 12 months to do it. The Commonwealth's made a decision to go forward in 6 months. That creates a lot of volume constraints. If the Commonwealth was going to go to 12 months, I might have a different view about it. But that's not where we're at. And so I think that we're really, there's a number of different things that have come up where decisions have been made that are creating a cascade effect. So again, if the Commonwealth continues to stick to a 6-month time frame, and I haven't heard anything otherwise, I think that really creates some challenges for the volume issue that continues to be a main driver here. If there's an opportunity to get the Commonwealth to change its position, I'm pretty open to thinking about, all right, maybe it's not that necessary because things are a bit more relaxed. But it doesn't really feel relaxed with what we've been given. I don't think much has been changed. I think we all generally have operated of trying to get to consensus, but realize sometimes that's just not going to be able to happen. And I'd say before we go forward with an official vote, maybe take a straw poll just to see where folks are at and see if there's any more opportunity for negotiation and room publicly.
Any other thoughts?
Yeah, I just, you know, I think from all of our perspectives, we were all, and, you know, it's the right thing and it was all good. everybody was asked to provide feedback, which we all did in all of our honesty and with the best of thoughts across our collective, constituents. And so that's all we had was the one data point of the feedback that we all provided. Maybe there was more, if there was, kind of sharing of that feedback, I'm not aware of it. But the pre-read for this particular vote, we didn't get until late yesterday. And so, there was no way to know that this was going to be the proposal that the board was going to put forward, because we've all given our feedback and we all feel strongly about it on one side or another. So I do think there's merit to giving us all a little bit more time. And, there's also a little, insurers don't like uncertainty, right? And the unknown. And, we all keep talking about big numbers and lots of people and lots of, people caught in this, difficult time. And insurers are being asked to bear the brunt of an untold amount of expense based on large numbers. Everybody keeps talking about large numbers. That's not in our pricing, right? It's not even right now in our contemplated pricing for next year. There's been really not enough time to think about the windows of when we all submit for risk adjustment, right? Because we all are going to share this burden equally. And so I don't really think that there's been enough time for us to really think through all the implications of this. So I would vote for, give us a little more time.
Well, can we,
Well,
oh, go ahead. In part, I would like to get, I'm open to, I think, persuasion about it, but I would like to see where the vote is initially. Not voting, a straw poll is just asking folks, where would you come down? If you had to vote today, where would you come down? I'm not using it to strong arm. I'm open to persuasion, but I would like to just understand where folks are on this issue, if they had to vote today. Is that too much to ask?
Okay, that's fair. We'll do it. So I'm going to do a roll call straw poll. I'm going to ask you yes, no on 6 months, yes, no on 2 months, and we'll see where people are. Jessica
Right.
Brooks.
Commissioner, it's 4 months. It's not 6.
I'm sorry. I don't know why I keep saying that.
My vote will be yes.
For either option, Jessica, that would allow retro.
Or
4 months or 2 months. Either option you're. Yes. Okay. Frank Fernandez.
Unofficially, my vote would be no on 4 and open to consideration on a shorter time window.
Okay. Antoinette.
Yes on 4, open to consideration on shorter.
Laval.
Yes on 4, open to consideration on 2.
Alexis.
No to both.
Paula.
Definitely no to 4. I, would be leaning toward no to 2, only because, literally, we've had a half hour to think about it. And I just, philosophically, I just, I don't know.
Sure. So what happens in this case, and Cheryl's abstaining regardless. So without the Commonwealth but weighing in. For 4 months, we have 3 yeses, 3 nos, and an abstain. For 2 months, we have 1 yes, 1 no, an abstain, and 4 people open to the idea of it. Is where
This is
the
Tia. I
straw
didn't
poll.
vote. This is Tia. I didn't vote.
Oh, I'm sorry, Tia, I skipped you.
Yes, so I'm voting yes, straw poll. And 4 months open to discussion of less than 4.
So 4 months, it's 4, 3 abstain, and then 3 Commonwealth votes. 2 months, it's 1, 1, 1, 2, 3, 4, 5 opens and an abstain, not counting the Commonwealth votes. Is where that would put us. So pretty mixed on 4. It would be a awfully close vote. 2 months, we don't really have enough information to determine where that would go. So recognizing that I've heard that some thought that there was more information, would be helpful to have more time. I mean, I think the other option is you potentially delay it while giving Zach and the Pennie admin team the authority to get it ready should it pass in the future, which the vote suggests that it would pass. So I think that
I think you guys
a
got to
couple-
give me, I mean, if you wanna defer votes on any policy now, I think I got to get some direction on what you want me to do in the interim. What you want us to kick the tires on, what you want me to bring back to this body at some later date.
Yeah, Zach, I don't think it's really fair for us to punt if we're not going to tell you get the retroactive coverage optionality ready, based at least on the straw vote. But I guess after the straw vote, I'm now interested in kind of what people may think.
What it's Alexis, I guess I would say that I would be interested in more detailed volume estimates for both the 4 and the 2 month option. And anything that we could kind of try to hang our hat on as a basis for projecting how many would use the retro. And I'm not quite sure how to do it because I haven't thought about it. But if you're asking us to be the last line of defense, us being the insurers on this, you know, to Laval's point, we also didn't make the 6-month decision, but here we are. Then I for one would appreciate anything that would get us a, you know, a better estimate of exposure.
Laval? Thank you, Alexis.
I understand that point on that, and I think it's I hear it in the spirit of it wasn't necessarily a part of the feedback, but I also know sometimes firsthand, left hand doesn't know what the right hand's doing, even in my own organization. So I think we might well take a vote on retroactive coverage, which I understand would be a split vote. But there likely is, and I'm open to education about this, there's a big difference between going 4 months and 2 months. And the big conceptual question is to move forward on is we're voting on retroactive coverage. The amount of time, I think we're still trying to have a better determination of. And open to hearing feedback about it. And maybe that's still trying to get as much time as we can. It's not a default that we're definitely would be going to 2. there still may be a strong sentiment toward going with 4 months and 120 days.
No, Laval, I think from a carrier perspective, we all said that we would be willing to go back to our respective organizations and think about too. But the option to the alternative to that is 0, not 4.
Yeah. Well, okay.
Yeah, Laval, as I think about it, I mean, I think clearly, I think retro would win today if we were to take a vote. So I don't know though that voting just to retro or not today, if we're going to punt the decision on how far. I don't know that we need to take that vote today, but instead could authorize Zach to build it and schedule a meeting. I would say pretty close. If we find out in a week whether the PHE is going to be extended, hopefully Zach could pull us together within the next maybe 2 weeks after that, maybe a little bit longer than that, but pretty quickly thereafter. Particularly if it's not going to be extended. If it is going to be extended, we have a little more time to look at the options. But I guess if we're not going to pick 2 or 4, I think we might as well go ahead, build the functionality, come back to decide 2, 4, or other. And it looks like Jessica has to drop in about 3 minutes. So I think at this point, my recommendation would be that we move to delay the decision on the number of months to allow the retro while authorizing Zach to build the functionality to make it possible. But I open it back up to the board.
Well, I guess, Mike, this is Jessica. What is the impact to Zach and his team to make that kind of change and take time away from other things without having, like, I guess that would be something I would need to know to agree to that. I don't want them spinning their wheels and taking away from other things they could be doing because we're not making a decision.
I appreciate that, Jessica. I think we can make it work. I also think that at this point we are not going to be able to get to the discussion of the NCQA health equity certification, which is not something that was going to be up for a vote today, but was up for discussion with the intent of getting some feedback from the board and direction about how to bring forward a vote in August. So I'd still like to have that conversation, and we're not going to have it today. So it kind of feels like we're going to have to come back together soon to at least have that. So I think, I don't know how to get what Alexis requested. And we'll have to think a little bit about it. I don't have any additional data available to me, nor do I think we will be able to get it to kind of get at it. But I think we can put something out to the insurers to, I suppose, try and quantify the risk as a follow-up. But, I think feels like we should punt on this decision today and come back to it in a couple weeks. And that would, the upside to that is that we get to also talk about the NCQA health equity certification requirement.
All that said, questions, comments, or I will accept the motion.
Just a question, Zach, are you saying that if we come back in a couple of weeks, you don't also need the kind of permission to proceed on the technical build now? Or are you still looking for that?
I think we need to start building it. Right now, Alexis, I don't know. I'm worried about waiting any amount of time. I also don't, to the extent that the ultimate product deviates very much from retro available 4 months, 2 months. To the extent it deviates from that, I think there's a risk that we'll be putting ourselves in a position of not being able to deploy it on time. But that, you know, I don't know, absent someone coming forward with an idea of doing something other than what's been discussed here today, I don't think that we're likely to deviate from what we've talked about. And so I think with all that said, and sorry, I'm, you know, answering your question a little bit on the fly, I think having the authority to start building now would be helpful, is important.
Laval, I see your hand.
So I think I would move to call to have a vote to authorize the Pennie staff to begin building models for retroactive coverage for the loss of MEC for a date to be determined based on additional input from stakeholders.
I'll second that.
There's second. I'm sorry, who seconded?
That was Frank Fernandez. Second that motion.
Frank. Any questions about the motion? We have a motion on the floor that's been seconded. Okay, so the motion is to authorize staff to build the model for retro coverage for a date TBD based on additional stakeholder feedback. And we will come together shortly to have that follow-up meeting. I'm going to do a voice vote unless I hear opposition. So all in favor?
Aye.
Aye.
Any opposed? Okay, let the record show that we have the unanimous vote, Zach, and we'll look forward to talking to everybody very soon with
Yes,
some
hey,
more
hey,
additional information
Mike,
that we
before
can.
I was going to abstain. It's Paula. I was going to abstain.
Paula abstains. With that, Zach, I think we end all the PHE agenda item discussion. It sounds like for time purposes, and because it's not until I think 2024, we're comfortable punting on NCQA either to our next special meeting or potentially to the August meeting. Is that right?
I think I'd prefer to punt it to the special meeting that we need to have to discuss this policy.
Okay. We will do that. I don't think we need a motion for that. We're just moving the agenda. So then the next part of the agenda is our executive session meeting. So Zach, I think that means for those of us that are on the board, in order to seek legal counsel regarding ongoing audits, which if conducted in public could violate a lawful privilege or lead to the disclosure of information that's confidentiality protected by law. The board members, we will leave this meeting open for the public, but the board meetings will drop off this meeting to join the executive session meeting before coming back to this meeting for anything that we need to do in public. So I will see many of you on our executive committee meeting shortly, or in our executive session meeting shortly. Thank you. All right, Zach, I see that we have the board members back on the public meeting after our executive session. Coming out of that session, I will be looking for a motion, and I think the motion would be to authorize Zach to submit the required corrective action plan to CMS as part of Pennie's SMART audit, respond to any questions raised, or make any adjustments requested by CMS, and upon approval, take the necessary steps to complete the corrective action plan and post the audit publicly in accordance with the law.
This is Alexis, so moved.
This is
Thank
Laval,
you,
second.
Alexis.
Seconded by Laval.
Second by Laval. All in favor?
Aye.
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 Any opposed? Hearing none. Zach, we have a unanimous vote in support of the proposed motion. And I think that brings us to the conclusion of our agenda. So I guess for board meeting members, thank you for bearing with me at my first board meeting. We will be getting together again soon after Zach gets a chance to get us on the schedule so we can come back to talk about the remaining policy issue and the future plan certification issue. So thank you all, and we'll get out here 15 minutes late, so apologize for that, but thank you all for your time. Take care.
Thanks,
you.
everybody.
Aye.
Thanks, everybody.